medical aid schemes industry is at loggerheads. Now, this follows a recent announcement by the Council for Medical Schemes that it intends to discontinue primary health insurance and low-cost benefit packages. Many seem to share the view that South Africa already has a struggling public healthcare system and an expensive private healthcare system, and therefore the move will further deal the poor a major blow. To help us understand what's actually happening, we are joined in studio now by Kerry Hertog from the Healthcare Stakeholders Forum. Kerry, thanks for coming in. Good to have you on Morning Live.
Thank you very much for having me.
Give us an understanding of what's going on. What has transpired now?
Demarcation, the exemption framework, low-cost benefit options, medical insurance, it's been a contentious issue for many years.
Yeah.
And end of 2016 and effective the 1st of April 2017, there was a framework that was put in place that allowed us to operate in a regulated environment to a certain degree, but under exemption from Council of Medical Schemes. If you're defraying, paying medical expenses, benefits, medical benefits, you are seen to be doing the job of a medical scheme.
Yeah.
And a medical scheme has a number of requirements. You have to have primary care benefits, PMBs. You have to have reserves to pay claims up to 25%. And it's a bit too much for medical insurance. We're low cost. You're looking at products between 300-400 Rand where it's unlimited GP benefits. Majority of the time there's an employer that's actually paying these contributions 100% to workers that wouldn't, even with a medical aid subsidy, wouldn't be able to afford medical
aids. And we know
yeah.
how expensive medical aid schemes are. It is insane, and they just keep on going up, and they make it so confusing that we actually don't even know what we're paying for.
What we're doing,
it becomes that confusing.
Exactly that.
But now with these LCBOs, is that what it's called? LCBOs.
Low cost benefit options.
Okay. Now they're wanting to get rid of this.
I think the term that is used is it's outlawed.
What does that mean?
So Circular 80 was issued on the 4th of December last year, and we've always worked towards the belief that there was going to be an LCBO framework for us to move the medical insurance products into within a medical aid environment. There would be leniency on reserves, on PMBs, on what we could and couldn't include, and that was where we were going with it. And that was imminent. It's March 2021 is when we were supposed to have that, and that's what we were focused on. The registrar withdrew it.
Wow.
He withdrew it as an option, and then further went and added a bit of salt to the wounds by giving us a Circular 82 that justified why he was outlawing it. He refers to an unregulated industry. He refers to players that take advantage of the poor. I don't think he knows who the members actually are. I don't believe he understands the products. He sees it from a medical scheme, and he's looked at the data from a medical scheme aspect and said there's 55% profit, which isn't necessarily the case. We want the opportunity to look at the data set that he looked at and say, well, this is what you're not seeing, and this is how you should see it, and allow us the opportunity to be more regulated if you're unhappy with the way we're being regulated. But as a healthcare forum, stakeholders, we want to have that engagement. But at this stage, after we've tried to engage, we had a protest last week. The registrar wasn't available to take our memorandum. They then negotiated that we would return today, and now there's a bit of a dispute over our return. So we can't go and discuss this, and we want to engage. We want to discuss.
So as it stands right now, you haven't seen that document. You don't know what the meat is that is behind the decision and what the registrar has announced. So you haven't seen that as yet, and that's what you're asking for: consultation and to actually see the data.
To see the data. So, well, how did you get to this conclusion, and why are you not looking at it from this way? Is it 7,000 members that you looked at? Is it 500,000?
How many members are we looking at approximately?
The material that they presented to us, they said 500,000, but we think it's more like 2 million. It's between 1 and 2 million, depending, and I suppose that's part of the unregulated part of it. Is it occupational health? Is it medical insurance? Who are the players? Who is being regulated, who isn't being regulated. But potentially there's 2 million people that are about to start accessing state healthcare.
But you do agree that there are problems with this industry, and that it needs to be regulated, and that decisions need to be taken quite quickly in terms of trying to fix it up and trying to, perhaps there are people out there that are preying on individuals, and this happens in every industry, and we do know this. But your complaint is that, to go and scrap it altogether without even trying to fix it up is a problem.
We want to engage, and we've waited for 3 years to get to that point. And the Council of Medical Schemes have shown time and time again, they had an LIMS framework, they had an LCBO that they issued in 2015, September 2015, and next minute was pulled for whatever reason. The work's all been done. There is a bit of tweaking that's needed to be done to make it more regulated perhaps, but to say it's outlawed and it's an unregulated industry, and then also to say laud themselves for having successful stakeholder engagements. I'm yet to meet that stakeholder that can say we've had successful stakeholder engagements with the council.
So no consultations whatsoever. This is just something that has come in as a surprise to you, and now you can't even have those consultations to figure out why you're in the situation.
They're setting up a task team. Again, 2 task teams, one for medical aid and one for medical insurance. But they want us to work together, but they're separating us again. It's just the frustration that's being felt. There's a lot of frustration being felt by the various stakeholders.
Yeah. So I still want to get a better understanding of what the registrar has said. You said one aspect was saying that, that it's unregulated, maybe 55% of the amount that's paid actually goes to the service provider as opposed to the person who is paying for this. These are just some issues, and you dispute this.
Yeah, 55%, the registrar is saying there's up to 55% profit.
Yeah.
So for every 100 Rand, 55 Rand's going to profit.
Yeah.
Whereas we're saying, let us look at the data. And keep in mind, they're talking percentage. So on a medical scheme, 1,500, 10% of that is allowed to go to non-healthcare expenses, and he's saying we've got 55% of non-healthcare expenses. But our 55 is 150 Rand, whereas the 10% of the medical scheme is 150 Rand. We want to protect the rights of the communities that would be affected by this, and we need the engagement to ensure that everybody understands what we're trying to achieve as a medical insurance, health insurance, low-cost benefit options.
Yeah, because again, there's talk that this is not actually working, that people that are on these LCBOs, and they have these agreements with state hospitals that when they arrive there, they don't know anything about it, and they entered into, and it's just, they might as well not be paying those benefits because they're not getting anything from it.
The low cost, well, again, that statement, I'd like to say who you're referring to, because I've worked with a number of healthcare insurers over the years, 15 years. I'm not sure who they're referring to. Yes, if the benefits are insufficient, they might be referred to a state facility. And again, if a state facility was able to raise an invoice, we would pay him the benefits that we would have available. It's not that there is no cover. We need to look at that data to understand the statements that they made. A lot of the low-cost benefit options are only primary health care, so it's out of hospital, it's access to a private GP who would do blood tests, give you chronic medication, acute medication, and it wouldn't necessarily include hospitalization. But we are also talking about a 300 Rand or a 250 Rand premium, where we're looking after people in a primary care out-of-hospital environment to ensure that they don't complicate and land up having to be in a public hospital or be hospitalized for a condition such as hypertension or diabetes. So managing the chronic conditions as best as we possibly can in that environment with a premium of 300 Rand.
So the information which you gave us at the beginning is that the 31st of March 2021 is the proposed date to terminate, scrap, and all it is really doing now is waiting for approval from the Minister of Health to sign this off and say that's fine.
Basically, yes.
Without any consultation.
As I said, they've set up 2 task teams. We think they're disingenuous about the task team that they're setting up. I don't think they're going to be moving towards a solution. They're separating the streams where the streams should be working together.
Well, that's an open invitation to the registrar to please come and explain this, because it seems that there's no real information that's being exchanged between the 2 parties, and it's just speaking into the wind, and the message is not going anywhere. So let's open this discussion, and I don't think it's the end of it. I think we'll pick this up and carry on with it. Kerry, thanks so much. Hopefully we can invite you again with some more developments on this. Kerry Hertog is from the Healthcare Stakeholders Forum, talking to us about the medical aid schemes industry. They're at loggerheads, following a recent announcement by the Council for Medical Scheme that it intends to discontinue primary health insurance and low-cost benefit packages. So we'll follow up on that story. It's just the beginning, as I say, of that discussion. Let's quickly